Okay, let's start then. Hello, everyone. Welcome back again to Club Breast. This is the second meeting as we started this in January with Professor Seema Khan about the surgery to the primary tumor in the metastatic breast cancer patients. And tonight, and I don't know where you're just logged in, according to your geography, maybe good morning or good night or good evening or good afternoon. Tonight we have another special guest and my colleagues, my co-chairs, Professor Nuran Beshe and Neslihan Cabioğlu will be presenting him. Well, they will be presenting you the whole details of our guest, but he's a very close friend of mine from the UK, and he will be presenting his one of the PRIME studies, which brought really a good insight to the breast cancer local regional treatment by radiotherapy, although he is a surgical oncologist. Please do not forget to write your questions or comments to the chat box. This is a web meeting. This is not a webinar. As you can see, all your videos, although you're turned off, is seen on the screen. So only correspondence can be done through the chat box. You may use chat box to ask your questions from the beginning at any time during the presentation. So we will be collating all those questions to convey it to our guest at the end of his presentation. So now I'm giving the microphone to my co-chairs, and I thank them both because they will be helping tonight until the end of the meeting, to Professor Cabioğlu and Professor Nuran Beshe. Yes, the microphone is yours.
Okay. Thank you very much, Bahadur. It's a great opportunity to meet Dr. Jayant Vaidya here. And you are making great organizations. I want to thank you for all these meetings. Dr. Jayant, kudos to all your success, all your publications. You have very interesting results and you have positive outcomes. We are really looking forward to hear these results and listening you. We have some radiation oncologists in the audience. So as a radiation oncologist, I will collect their questions at the end. I'll ask them. I also have particular questions to you. Now I'm leaving microphone to my co-chair, Neslihan Cabioğlu. She's going to make the introduction of you. Okay, Neslihan.
Hi, good evening. I would like to welcome everybody that already joined us. It's my great pleasure to introduce Dr. Jayant Vaidya today. Dr. Vaidya is currently a professor of surgery and oncology, Division of Surgery and Interventional Science, University College of London, module lead for professional surgical practice, UCL Medical School in London. His surgical residency is in Mumbai Government Hospitals, and his senior residency and fellowship in surgical oncology at Tatya Memorial Hospital in Mumbai. He is also a member of British Association of Cancer Surgeons and Association of Breast Surgeons, and he has been the clinical lead of a busy breast center with one high scores for patient satisfaction in London. Professor Jayant Vaidya conducts groundbreaking research in breast cancer surgery, radiotherapy, oncology at University College London. He is a world-renowned expert in the field of breast cancer. Along with his colleagues, he developed and scientifically tested the procedure of targeted intraoperative radiotherapy, TARGIT IORT, using intrabeam during lumpectomy for breast cancer. TARGIT IORT procedure has been used for over 45,000 breast cancer patients treated in 260 centers in 38 countries worldwide. We would like to thank him one more time for accepting our invitation to join to this journal club as a presenter. And he is going to talk today about long-term survival and local control outcomes from single-dose targeted intraoperative radiotherapy during lumpectomy, TARGIT IORT for early breast cancer, TARGIT A randomized clinical trial. Yes, Dr. Jayant Vaidya.
Thank you. Thank you very much. Tell me when I should start. Should I share my screen now? Okay.
Yes. You can start now. Share your screen.
Good. Okay, so there the screen is shared.
Yes.
Okay, so that is good.
Very good.
Okay, so thank you very much. Thank you, really. It's a great pleasure to come and talk to all of you about this. I'll talk about targeted intraoperative radiotherapy. Target is a word I coined for that targeted intraoperative radiotherapy, and you can see how the pink words make up target. And it's sort of a pun on target. So, and these are the list of authors of the last papers. So really, what I'm going to talk about is challenging the dogma of radical radiotherapy between 1960 to 1990. So we changed radical surgery between 1960 to from 1894 onwards. So from Halsted mastectomy, we come to very targeted surgery with localization and very clear, precise operation as little as possible. So what we have tried to do from 1995 is to challenge whether radiotherapy also can follow the same path over the last 25 to 30 years. And what was nice for us is last year, National Institute of Health Research, out of the blue, posted this: 5 amazing health research breakthroughs, and they listed Target among the breakthroughs. And it was nice to be included in the list, which included the COVID vaccine and 2 COVID treatments. So this came out of the blue, and it was just nice to see that. So why could it be breakthrough? This is a list of things that one can make. And this is sort of the summary of what the benefits are. It is convenient, it is easier for the patient, it's less expensive, it's simple to deliver. Even a surgeon can do it. It is devised by clinicians, by a whole team, and it is finished during lumpectomy. You can individualize it, it's accurate, it's timely, and we have been doing it for over 20 years. And we have long-term evidence, which I'll show you. There is an overall survival benefit for grade 1 and 2 cancers. And it can also be used for local recurrences when, or in those patients where EBRT is not possible to avoid a mastectomy. So I must thank every patient, clinicians, and the teams in all the hospitals who took part in these trials, over 38 centers in 15 countries. So this is the International Steering Committee, which was the initial one. And then this is the NIHR appointed Trial Steering Committee. And these are the photographs of the authors of the last papers in 2020 and 2021. This is the potential conflict of interest. We get grant funding to UCL from NIHR HTA, and I have received travel reimbursement and honoraria from Carl Zeiss. So this is something which is very basic. Is the main treatment of breast cancer is a lumpectomy or a mastectomy. If you do lumpectomy, standard of care needs to include radiotherapy. Otherwise, there is higher risk of local recurrence. Radiotherapy is not usually required if you do a mastectomy unless there are certain high-risk factors. So this is a short cartoon in which after the cancer operation is done, the woman has to go back and forth to radiotherapy center. And as has been the standard of care all these years, from 6 weeks, it has come down to 3 weeks. And I'm still not sure about the 5-day regimens with a higher toxicity. So it is a lot of journey for the patient. And this is a video taken by Mr. Nathan Coombs, a surgeon who works in Swindon. And, oh, it'll work. So this is a video he took along with his son while traveling from
3 or 4 weeks.
Start again. Okay. It worked earlier. That's fine. Okay. So what we calculated, and this is a journey, you can see the video in a few seconds if it comes on, but the important point was we actually calculated that every patient receiving IORT would save 750 miles of travel. This is in the UK, 30 hours of traveling and 215 kilograms of carbon dioxide. So it is actually could be reducing global warming as well if we use it all over the world. This is one. Secondly, the harmful effects of scattered irradiation after whole breast radiotherapy are very well known. So it causes radiation of vital organs nearby, like heart and the lung, and it does increase risk of heart attacks, and people can develop cancers which are much worse than breast cancer, like lung or esophagus. And this risk is significantly more if the patient has been a smoker. Now, this is a very interesting finding from the Oxford group, in which they found that 23% of smokers who have external beam radiotherapy will die, not just get the cancers, but die from this. This is a 6% rise. Now, one cannot expect any type of radiotherapy in early breast cancer to reduce mortality by 6%. That is a large number. So the benefit of TARGIT is even more in smokers. It's a much safer option. So this is what my point is: should patients be obliged to choose a mastectomy? And I faced this myself when I was a resident in Tata Memorial Hospital in India. And so this is the human and the social side of this. After telling the patient that you have breast cancer, the next question I had to ask them was, can you come to the hospital every day for 6 weeks of radiotherapy? And if the answer was yes, we could preserve the breast. But if the answer was no, we would have to do a mastectomy. And this was not limited to India. It happens in America, on the West Coast, where people don't want to cross the Bay Bridge. It happens in Australia, outbacks, people don't want to come. They say just do a mastectomy. Happens in Denmark, in Europe, where people don't want to travel from their island. Or even in the US, in the UK, as you saw, there's a lot of distance to radiotherapy centers. So this clinical concern, the travel plus the toxicity, was combined with the laboratory work, which I did in Tata Hospital, in which I found, after doing a whole organ analysis of mastectomy specimens, slicing the breast for patients who had small cancers, and I found that they had more than one cancer. And this work has been done in the past. But the new part about this study was that I plotted them in 3 dimensions. And I found that a breast with a single tumor has multiple small tumors in other parts of the breast in 2/3 of patients. Now, this is in contrast with what happens when you get local recurrence. More than 90% local recurrence occurs around the primary tumor, early local recurrence. And if it occurs in the other quadrants, it is at the same rate as it occurs in the other breast. We don't treat the other breast, so why treat rest of the breast? So this was the point of this translation, was to sensible to target radiotherapy just to the tumor bed. So with this biological rationale, we published this, presented in Hong Kong in 1995. We published it in 1996, and we wrote about it in the Lancet. So this idea that local recurrence could be, because it is near the primary tumor, combined with the academic insight that we could irradiate only the primary tumor. Luckily, it came along at the same time when Photoelectron Corporation approached Professor Michael Baum and Professor Tobias. Oh, we have a machine which we may be able to use. And it was not prepared for breast. So we created new applicators to use it in the breast. And then we did the first pilot studies and then the TARGIT A trial. So this was developed in UCL Middlesex Hospital towards the end of last century. And this is the way the applicator goes in the tumor bed. It's a very simple technique. We deliver radiotherapy immediately after lumpectomy, focused to the tumor bed, and avoids normal structures such as heart and the lung. And you have individualization here. Small tumor, for small tumors, you have smaller applicators. For larger tumor, you have larger applicators, so that when the tumor cavity is bigger, from 1.5 to 5 centimeters, you can give radiation by wrapping the tumor bed around the applicator. And this is during COVID times. It is much nicer for the patient not to come back to the hospital again and again. That's the machine. This is the operation theater. This is the patient lying here. And this is going inside the tumor bed, as you can see here. And you can see this is how it looks. This particular photograph is from South Korea, where I went there for showing them, and they're taking part in the TARGIT B trial. So it is COVID safe. So this technique, based on an academic insight, was developed. The first patient was done on 2nd of July, 1998, and that's Professor Michael Baum and Professor Tobias. This photograph is taken in Aviano. This picture was taken in Aviano in Italy. So Most of us are surgeons, and in fact, most breast cancer treatment is completed by the time you remove the cancer. Anything further is adjuvant therapy. And this is a way I can show you a small video of how to take a purse string suture to wrap the breast tissue, which is very pliable, around the applicator. So you choose the applicator size according to what the tumor bed is, and you wrap it around. And once you've finished the purse string suture, you can put the applicator in and tie it around it, as you saw in the video just now. We must make sure that this suture is not too close to the skin, otherwise skin could get burnt. So too much radiation. And so this is a diagram that shows how this distance of the applicator to the tumor bed should be at least 8 millimeters. We published the technique in 2002, and the first 25 patients of giving this as a tumor bed boost was published in 2001. And then we started the randomized trial in 2000. So publications came, but we started the trial already in March 2000. Asking the question, can risk-adapted single-dose radiotherapy during lumpectomy effectively substitute 3 to 6 weeks of radiotherapy postoperatively? The recruitment occurred between March 2000 to July 2012. So this is the gold standard of testing a new treatment, comparing radiotherapy given during operation versus whole breast radiotherapy. And trial started in year 2000, so we have long follow-up. What is important to recognize is it's a very large clinical trial. Recruitment eligibility was very broad. Anybody over the age of 45 with a single cancer was eligible. There wasn't any particular exclusion criteria apart from lobular cancers, so invasive ductal carcinoma. And tumor size, preferably less than 3.5 centimeters. And importantly, MRI was not required. And in the trial, only 5.6 or 5.7% of patients had an MRI done. So this was the randomization. We realized that sometimes postoperatively, you may find a patient is very high risk, in which case we said, sorry about that. We said that the radiotherapy, external beam radiotherapy, could be added to the patient, right? Next. So we published our first result in July 2010, and that time, Lancet put our conclusions on the front page, saying that for selected patients, this should be an alternative for external beam radiotherapy. We published our results again with the first survival results in the Lancet in 2013, and we confirmed our initial conclusion. So while waiting for the long-term results, the many obvious benefits were confirmed in the following studies. We showed that the cosmetic outcome is superior in 2003 and then again in 2013. That quality of life is superior, and these studies were done in Germany and in Australia, where the cosmetic outcome, breast-related quality of life, radiation-related quality of life parameters were better with intraoperative radiotherapy. Patients have less pain, less breast and arm symptoms with IORT. So this was done in this study was done in Denmark. Sorry about this. Patients prefer target IORT. They would prefer to have target IORT if they were patients. Doctors prefer target IORT, given the results which were published even before the last results. So these studies were done in US and in Australia. And this is a study done just last year. This is a study in Kaiser Permanente in Western America. Patients older than 65 with early breast cancer were asked, do you want to have no radiotherapy because of the prime 2 and low risk category? Do you want to have whole breast radiotherapy? You want to have mastectomy? Or do you want to have IORT? And 75% of them chose to have IORT. So when it's available, they want it. This is what patients want. Given the results which were published, this was in March 21. So the last results, the study was conducted before the BMJ results were published. It is also cost saving. In the US, over 5 years, it would save $1.4 billion. So for the economy of any country, giving target is saving the economy and the society money. In UK, the cost is less because, so saving is less because the cost of external beam radiotherapy is much less than in how it is in the US. And we have seen how the environmental and social benefits are there. Sorry about this. This phone is. And so this is what I showed you about the travel. Now, this is a very interesting biological fact that we found in 2008, that TARGIT seems to improve tumor microenvironment. So after surgery, and many of us would get very scared when they learn this, after surgery, the fluid that collects in the wound stimulates cancer proliferation, cancer cell motility, and cancer cell invasiveness. And this work was done in Italy by Dr. Samuele Massaruth and Dr. Baldassare. Sorry about that. And but what was interesting was when you give patients IORT, the fluid that is collected in the wound after that, that doesn't stimulate cancer cells. You can see how it is different in the top wound, which is they're stimulated and moving around fast, and the bottom wound, they're not walking around too much. So this seems to be an effect independent of the dose. So even a small dose will make that tumor environment not very conducive to the growth of tumor cells. Okay. This phone is just getting into a problem here. Okay. So this is the summary. Compared with external beam radiotherapy, it has better cosmetic outcome, better quality of life, less pain, less breast and arm symptoms. Patients prefer it, doctors prefer it, it's cost saving, and it reduces patients' travel to the hospital. Oh my God. Okay. Okay. So it's a randomized trial now. We want long-term follow-ups. The first patient was randomized in the year 2000, and long-term outcomes, well, data lock was in July 2019. And for completeness, we set the bar high. And you can, so now this is where we said the bar. Follow-up was considered complete only if 95% patients had at least 5-year complete follow-up, and 90% had at least 10-year follow-up or was seen in the previous year. So we knew this.
We have lost 2 patients. I'm so sorry about that. One has immigrated to Finland and one have immigrated to Bulgaria.
And this is out of how many patients?
As out of 534 patients, we have lost 2, and I'm so sorry for that. I'm trying to get data on the lady who immigrated to Finland. I got a phone number, but she don't pick up the phone. But the one who immigrated to Bulgaria, I'm sorry to say, I think I lost her.
So this is from Copenhagen, and it is really this is the quest where we got follow-up. Okay, teams from all over the world helped us to get this data to 95% complete follow-up. This is the team of Situ at UCL, and TARGIT A has the largest amount of follow-up data in partial breast radiation trials amongst invasive breast cancers. So this is, each color bar is the years of follow-up. And so you can see how high the numbers are in terms of number of patient year follow-ups in TARGIT A trial. So we have seen the advantages. And patient is, what is the patient thinking? What is the chance of my living without cancer coming back? And these are the results. Published in the BMJ in August 2020 and in British Journal of Cancer in May 2021. And these papers are available for free as PDF online. So these are the long-term outcomes. First question, what is the chance of remaining cancer-free in the breast? So remaining local recurrence-free. And this chance is no different between TARGIT and external beam radiotherapy for local recurrence-free survival, any local recurrence, and for invasive local recurrence-free survival, just invasive. What is the chance of my preserving the breast? And here we find that there is no difference in the patient mastectomy-free survival, that is chance of preserving the breast. What is the chance of remaining distant disease-free? There is no statistically significant difference here. In fact, TARGIT is slightly better, but it's not statistically significant. Freedom from distant disease is no difference. And this is local control as per treatment received. So patients here, you have patients who receive TARGIT plus EBRT, and those who were randomized to TARGIT and did not receive supplemental EBRT. There was no difference in local control compared with external beam radiotherapy arm. So this is a supplementary figure in the BMJ paper. Now this is a very interesting thing, and this is published in the BJC. We know how local relapse after whole breast radiotherapy has poor prognosis, and it has been shown in EBCTCG how if at 5 years there's a difference of 20% in local recurrence, that there is a difference of 5% in mortality at 15 years. So after local relapse, many times it's a harbinger of poorer prognosis after having whole breast radiotherapy. And this is what we found. If you can see here, the top line, the red line, is patients who had local control, local recurrence after whole breast radiotherapy. The hazard is high of dying from breast cancer. So you can see that these patients who have local recurrence after whole breast radiotherapy in the TARGIT A trial had a higher hazard of death. But if you get local control, long-term hazard, if there's local relapse after TARGIT IORT, there is no higher hazard of death. It is same as having no radiotherapy. Oh, sorry, having no local recurrence. So we know that patients who have IORT, if they get local recurrence, their prognosis doesn't become any worse than it would be without local recurrence. So, sorry, these slides might have been repeated. So the excellent prognosis, even after local recurrence, as good as without a relapse. This was a very interesting finding. Another finding was that local control is similar in all subgroups. And here I want to focus, say that again, this trial did not have just low-risk patients. You can see that 60% patients are under 65, okay? 70% patients were under 70, 20% were grade 3, and these 20% is actually 400 to 500 patients. So we had 400 to 500 patients in the trial who were either grade 3 or node positive or ER/PR negative. So the large number of patients had high risk factors. Despite that, local control was as good as standard radiotherapy. So comparable local control. Next question was, what is the chance of survival from breast cancer? So this graph shows breast cancer mortality and the lines are overlapping. This is a magnified graph which shows no difference in breast cancer mortality. And this is the interesting finding, is that there were fewer deaths from causes other than breast cancer, mainly because of fewer deaths from heart attacks, lung cancers, and other lung problems and other cancers. And this is a big difference in statistical terms as well as in clinical terms. 4%, 4.5% difference is not a small amount at 12 years. So this is not a surprise to people who know about radiotherapy, because as we have said before, it does have, radiotherapy does have effects on close by organs, and it starts happening very quickly. So this study published in 2003 showed how within 6 months, you get cardiac perfusion defects in people who had radiotherapy. And the cancer incidence is increased significantly, and these are dangerous cancers, much more dangerous than breast cancer. And this is much worse among smokers. So is there any other reason? Now, this is a very interesting phenomena which we found in the trial, which we are going to test in the TARGIT B trial now. Now, look at this carefully. We had a difference in non-breast cancer mortality. One of the causes is avoidance of external beam radiotherapy. So let's look at that carefully. So patients were randomized to have EBRT or external IORT. This is the difference found, right? Now, patients who were received IORT had additional EBRT or no additional EBRT. So this is 241 patients who had additional EBRT, and these people did not have additional EBRT. Now, if you compare EBRT with those who did not have any additional EBRT, will tell us an answer in a pure term. Does avoiding EBRT reduce non-breast cancer deaths? Because it is a comparison between TARGIT and EBRT. And yes, there is a difference in non-breast cancer deaths expected from what we know of the toxicity of EBRT. But what about this other group? The other group received EBRT and received TARGIT. Compare them with EBRT. Now remember, these comparisons are not randomized comparisons. What did we find? And we had found this when we analyzed it in 2012, and we have again found it now. There's a significant reduction in non-breast cancer deaths, even when you get whole breast radiotherapy. And this suggests what has been recently checked. So we get this difference, avoiding EBRT gives difference, and giving TARGIT seems to make a difference. And this could be because of what is called as an abscopal effect, and that seems to start immediately after surgery, rather than after 2 years, 2.5 years. You can see how the lines separate here quickly. It could be a drug-like effect, possibly what is called as an abscopal effect, away from the site of radiation. And a lot has been studied. This is probably an immunological stimulation because of a high dose given to a small area. And there have been a lot of studies that suggest that it happens elsewhere in the body. This effect from intrabeam has been seen in the brain as well. So we have seen how type of studies are, local control is no different. But in terms of overall survival, what we found is in grade 1 and 2 cancers, there's an improvement in overall survival with no detriment in overall survival for grade 3 cancers. So this overall survival difference is statistically significant, and it's about 4.5% in grade 1 and 2 cancers. And these are 1,700 patients. So it's a large number of patients in here, and 1,797 patients, 10%, 10.5 to 15% improvement, and unchanged in the 443 patients who were grade 3. So this is the difference gain. Now, to put that in perspective, if you see comparison with trastuzumab versus placebo in HER2 positive patients, it reduces from 15% to 10%. So giving patients trastuzumab will improve their, reduce their mortality by about 5%, which is similar to the improvement by giving intraoperative radiotherapy. Trastuzumab impacts on the heart in a bad way, and IORT actually protects the heart. So the new insights from the recent paper are that we have got evidence-based guidelines because we know that this is where it works in all patients. If you want to know while you're giving target which patients should have whole breast radiotherapy, you can visit this website, target.org.uk, add RT. You can put in patient characteristics and they'll tell you whether this patient should have whole breast radiotherapy or not. And you can go scan this code to go on that website. And we found that local recurrence don't have the same implication. And we found a possible abscopal effect of intraoperative radiotherapy. So these are the first results published in 2010. And the long-term results confirm the initial results that it's effective in all tumor subtypes. There's a decision aid with local relapse has better prognosis, and it reduces non-breast cancer mortality even when EBRT is given. Now, this got a lot of publicity. We featured on the top of the front page of the Times, along with Joe Biden before he became a president. And so this is the point I was trying to make earlier, that 85% of patients were under 75 years of age, and a large number of patients had high-risk tumors. And this is different from those trials of no radiotherapy or trials of most other PBI trials. This is much more high-risk population. So the question is this: is no radiotherapy a good idea? Now, for that, we have PRIME2 trial. And in that trial, which results were presented in December for San Antonio meeting, where at 10 years, 9.8% patients got local recurrence. That is a large number. And 80% of these patients survived for 10 years. So 1/10 of your patients getting local recurrence is not a good idea, despite selecting extremely good prognosis patients over the age of 65. So this is not a good idea, and patients don't want it, as we saw in the study from US. Is the highly compressed 5-day schedule a good idea? It's much higher dose. It still has 7 extra visits, and 25% get 15 visits. The whole breast is treated. And to me, it's not forward, it's a backward step to treat the whole breast. And it still radiates the surrounding nearby organs, vital organs, heart, lung, esophagus. And in the breast, 25% patients report hardened or firm breast, as published in the Lancet paper. So there is breast induration is 19 times higher as per physician assessment. So I'm really skeptical. And this is even at 5 years. And these fibrosis changes get worse with time. So that's why I don't think this is a good idea. So this is the fast forward study. And I'm really concerned that it was pushed as standard of care during the pandemic. So there is no reduction in mortality. There are other methods of partial breast irradiation. When patients are not suitable for target, I felt, well, they should at least have other methods. And that's when I started comparing them. Giving brachytherapy, a patient should be shown this photograph. This is what is going to happen to you if you get brachytherapy. I don't think patients will really love to see that going through their breast, so many wires. It's additional procedure. You need lead-lined walls, 10 doses over 5 days. The trials of external beam whole breast radiotherapy have found poor cosmetic outcome. The rapid and import low trials. There is probably not so bad cosmetic outcome in the Florence study, but it was a very small study. And we know the results of TARGET now. And if you see this paper, and you can scan this code published in BJC in February last year, we have compared various options of giving different types of radiotherapy in this paper. And you can see tables there about whole breast and partial breast radiation. We have published in other journals, Red Journal, showing that it is better for patients and that there is powerful evidence now to change practice. This is in Nature Reviews Clinical Oncology. And there are studies from all over the world now. There are real world data. This is from US. This is a study from China where all inclusive patients were done. There were a cohort study, propensity match study, where the results are very similar to TARGET. You have France, which shows how 675 patients with 5-year follow-up, very good results. And this is a study from Europe, from 4 countries, Germany, France, Denmark, and Switzerland. Again, low local recurrence rate. The ELIOT study was published recently, last year, and it is very different from TARGET. And this, you can access this diagram published in the Lancet Oncology, where a lot of tissue dissection occurs when you have to give ELIOT. And that could reduce the efficacy of any radiation because radiation requires oxygen, good oxygen saturation. And this may be the reason why ELIOT type of radiation with Mobitron or Novac 7 might have a much higher local recurrence rate. With TARGET, the tissue is fresh. There is no disturbance of the tissue, of the breast tissue, and radiation is given from within the breast rather than given from outside in that manner. So there is that's a difference between types of IORT. So you can't put all IORTs in the same boat. Similarly, ZOFT, there is much higher local recurrence rate. It can be used during cosmetic surgery. This paper comes from Germany, 149 patients, where after doing, they give the radiation to the tumor bed because a radiation oncologist won't know where the tumor bed was after you've done oncoplastic surgery. So as part of oncoplastic surgery, you can make sure you give radiation to the right place at the right time. So this first results were published were presented in San Antonio in 2012. And then we have had meetings in Germany, and some of you may have attended these in Mannheim since long time, where there were few people in the beginning, and these numbers kept increasing with time. And US, this is Bangkok, Thailand. This was again in US, Germany, US, and this was just before the pandemic. And this map shows the centers around the world where IORT has been offered, TARGET IORT has been offered to patients with breast cancer. And that is where I asked each of these centers, tell me how many patients you've treated, which is from where the number 45,000 comes up. And that was in October 2019. So since then, I think that number might have crossed 55,000. So centers are there all over the world, really. So it has received press coverage around the world, and NICE gave approval to this as provisional approval in 2014. And Australia gave approval in 2015. And during the COVID pandemic, most centers reported they have begun treating many more patients. BASO made a recommendation that patients should be offered IORT for if it's available, because then that would avoid them from coming for radiation. So these are the benefits of IORT. What could be the harm? Now, this is written by Dr. Anthony Zeitman, who's editor-in-chief of the top radiotherapy journal, where he said, depending on your perspective, this could be either a very serious threat or quantum leap forward. Now, it will not be a serious threat if payment is made by value and there is no fear of reduced income to hospitals and healthcare staff. So this talk, which I've given up to now, was about TARGET A trial, which has long been completed recruitment. Results are published. TARGET B trial, that is TARGET Boost, is currently recruiting and is open to new centers. And we expect, because of the biological effect on the wound fluid, because it is given at the right time at the right place, because our previous studies showed a reduced local recurrence rate. So this paper was published recently, not recently, 2017, where we found the boost after neoadjuvant chemotherapy seems to improve local control and overall survival in high-risk patients. So, but this is a non-randomized study, and we are currently recruiting patients who are under 45 or over 45 with high risk factors or post-neoadjuvant chemotherapy in this randomized trial, where we want to recruit 1796 patients to receive target boost or no target boost, and then receive whole breast radiotherapy as well. We have now recruited already randomized 1,571 patients in 38 centers in more countries than before, Europe, US, South Korea, China, Middle East, and South Africa. 370 were recruited during COVID. So these are the conclusions. And if anybody wants a single slide of all the results of Target A, this slide shows all 4 outcomes with similar breast cancer outcome, reduced non-breast cancer mortality, and improved overall survival. And I leave you with this last video.
I'm Marcel Bernstein. 8 years ago, I was diagnosed with early stage breast cancer. I had it for 2 months only before I was cured. I had TARGIT IORT at the same time as the operation to remove the cancer. I spent 1 night in hospital and I was back at work within days. No pain at any time, no complications, no scarring. I can't even tell where on my breast the surgery was. And no recurrence. 8 years. And that isn't just me being lucky. Studies show that my experience is similar to that of other women who've had TARGIT. I am so happy I was able to have this treatment.
So thank you very much for giving me the time to listen to this. And I really do hope that you're able to use this in your patients. And if you can, take part in Target B trial. Thank you.
Okay. Thank you very much, Dr. Jayant, for your excellent presentation. I look at the chat, but there are no questions from the audience, and we are waiting questions. If there is not any, I can start by asking you, if it is okay for you. Well, let me start. The results are really interesting, particularly that's causes from other reasons. If I understood correctly, when you give external beam radiotherapy, we all know that there is a risk to scatter doses to organs at risk, like cardiac tissue. But in your study, you first give targets, and there's a group of patients who also received complementary external beam radiotherapy, and you compared this group with the group of patients who received external beam radiotherapy, and still the risk of dying from other causes were less in the group of patients who received targets. Yes?
Yes.
This is true.
This is what it is. Yeah.
Yeah, how do you explain this? You explained also in your article, but it is not satisfactory for me.
No.
I'll be very happy if you explain this
Okay.
again. Okay.
It appears that what is called as an abscopal effect, in which there can be an immunological effect of a high single dose of radiation. And it has been
you know that from SBRT, but it's a tumor killing effect.
I know. So this is what is interesting. Now, whether this effect is real or not real, we will know when we analyze Target B trial, because Target B trial has target plus external beam plus boost plus external beam.
Okay.
And that's a randomized trial in which we can compare this. The comparison we have made here is within a randomized trial, but the 2 groups were not randomized in that manner.
Okay.
So we will know whether this seems to be a real effect, it is persistent, but we will know whether it is real or not when we analyze the Target B trial in the future. But whatever happens, there is a clear reduction in non-breast cancer deaths.
It is very interesting. So why we do not see in the ELIOT trial, also they are giving the high single dose irradiation, but we do not see this result that we see in the targets.
I know, but if I looked at ELIOT trial results, I don't know whether they have analyzed the patients according to cause of death. We had a special committee who looked at the cause of death carefully and analyzed them and did special rules. And the person who did this did not know which arm the patients were in. So it was very carefully done, and who said this is the cause. If patient had any recurrence of breast cancer, it was called breast cancer death. And the remaining were non-breast cancer deaths. And the number of patients in ELIOT were only 1,100. And we don't know how radiation goes in that manner. And other thing people have said is in ELIOT, when you give radiation in this manner, and if you don't put the shield, and in some patients shield was not put in, it would go all the way to the back.
Well, I'm an ELIOT guy to admit, and we put the shield to every patient. So
Okay.
also we
Well,
work
this is
with
what I've heard. So,
the-
I mean, it's possible. If sometimes shield is not there, that could be a problem. Sometimes the thing can be there and the shield, if shield is a big shield, so generally you will protect. So, and I don't know the answer. But if you look at DCIS studies, it is suggested that you can't see it in DCIS studies or studies where with no radiotherapy. If you look very carefully, if you look at, I'll tell you one study which I have looked at carefully in the PRIME 2 trial. In PRIME 2 study, if you look at the abstract in San Antonio, there are more deaths from breast cancer and there are less deaths from non-breast cancer. So they are sort of compensated for each other. And I think what happens with TARGET is that the breast cancer control is as good. So the benefit of non-breast cancer death is improved.
Okay.
So I think that's what has happened. If the control, it should have been seen in PRIME 2, but in PRIME 2, the number of non-breast cancer deaths was not significant, they were lower in numerically, but the trial was half the target size. So they were lower non-breast cancer death and higher breast cancer deaths. And I had a slide about this, but I don't have it just now. But PRIME 2, that's what happened. It is on the slide, which says it looks like the higher breast cancer deaths compensated for the lower non-breast cancer deaths. And other thing is, in olden days, when this was being seen, 40–50% people died of breast cancer because the breast cancer was very poor prognosis. So here, only 5–8% people died of breast cancer. Therefore, they lived longer and therefore they could die of other causes. So the number of people dying of other causes was much more in the TARGET A trial than in historical controls, in historical patients. So I think because of that, it has unmasked this benefit.
Okay, very interesting. And another interesting result is the outcome after the recurrences of target. You know, the outcome was good after the target recurrences compared with the group who received external beam irradiation.
Yes.
So did you look at it if they were really true recurrences or in-breast recurrences?
Well, we didn't. So what happened was in TARGET A, firstly, there were 12 DCIS recurrences. In EBRT, there was just one DCIS recurrence.
Okay.
So it could be that. But also some of the new recurrences in TARGET A might be new cancers rather than recurrences.
Yeah. So they have good prognosis and that might be the reason.
So that might be the reason. And second, more importantly, the mastectomy-free survival also was not changed. So patients didn't have a problem because they had local recurrence, because after TARGET, you can actually, if there's a cancer appears here, another cancer appears here, you can remove it and give IORT. So you can preserve the breast after local recurrence.
Yeah, I see. And another interesting thing, it's really interesting. It is very interesting for me. I'm stressing it. The patient population is high in your group, in target group, isn't it? You have a triple negative patients or two positive patients, unlike the other intraoperative radiotherapy, ELIOT, for instance, or even PRIME and the other Budapest trial. I do not like to compare different trials, but the prognosis, the local recurrences are really low in your study.
Yes,
So,
it was 2.5%. I mean, that's local recurrences in total. There were 48 versus 24 overall invasive local recurrences. So it is really 2% versus 1% at 5 years. And when you start analyzing beyond 5 years, people die. And if you only look at local recurrence incidence, the number is wrong if you do it only by local recurrence. So you have seen publications in which you say cumulative local recurrence 5 years, 10 years. By the time you reach 10 years, if 20% people have died, you can't have a local recurrence of 2% or 5%, because then it would imply that 95% people are alive. But only 80% people are alive, which is why when you have longer follow-up, all the guidelines, American and European guidelines, say that you must include mortality, deaths, when you talk about local control in the long term. So, and patients also want to know what is the chance of her living without the cancer coming back.
Sure.
Not the chance of what the local recurrence might be if she lives for 10 years. Because you have to be alive to live for 10 years, and no trial, everybody's alive for 10 years. So that is why pure local recurrence, which people want to know, is not practically possible unless you have a population which doesn't die.
Yes. And my final comment, you have excellent results, very interesting results. So why intrabeam is accepted as investigational by ASTRO?
Well, I don't want to be accused of any libel, but Dr. Anthony Zeitman has said it in his article. He has said, I didn't put everything what he said, but it is published by him saying that a lot of people's career depends on fractionated radiotherapy being given.
I know that, yes. Each fraction costs money. Yeah.
And it is not right to say it, but when patient's power comes in, and if the remuneration is according to the value, the support Obamacare came in America, the cost of radiotherapy is fixed. Whatever type of radiation you give, it doesn't matter you give it in 1 fraction, 5 fractions, 30 fractions. Everybody will want to use IORT.
Okay.
That is, I'll tell you one thing that definitely happened.
Okay.
In America, whenever I used to go for those meetings, there used to be 2 radiation oncologists, 5 radiation oncologists, and 50 surgeons. And one year, suddenly there were 50 surgeons and 50 radiation oncologists. And I asked what happened. They said, oh, they got a code for radiotherapy now, for IORT. It is not good. This is not nice, but it is what practically happens in real life.
I know.
And I didn't expect this. Yeah, so it is. And there is also one more thing. This challenges what radiation oncologists have forever thought, how much dose is required for the radiation. And it challenges the basic understanding. It's like surgeons not wanting to give up mastectomy and surgeons not wanting to give up axillary clearance. So because, oh, that's not enough for us. So that is the problem. So I think it is both, not just financial, it's also psychological and basic principles of treatment, what we have learned. If they are changed, it's not easy to change it.
Okay. Dr. Vaidya, I would like also to thank you very much for your comprehensive, very nice presentation. I have also some questions regarding your presentation. So what is your management strategy for patients with a positive margin in final pathology, definitive pathology?
So this was in our protocol. In protocol, if the margins were positive, we would re-excise the margins as you would normally do. Okay. And in the protocol, it was 1 millimeter margin. Now we accept tumor on ink. If it's not there, it's okay. And if that happens, the protocol said you should give whole breast radiotherapy without the boost. Okay. Okay.
So,
but only half the people who get positive margins in the trial received whole breast radiotherapy.
Half of them.
Only about half or 60% received them. But despite that, these are the results.
Okay.
So margin is positive. More people got whole breast radiotherapy. Yeah.
My second question is, how can you explain the difference in the ELIOT trial? I mean, that was published last year, as you know, their long-term results. So they observed more local recurrence compared to those who received external radiation. So how could you explain, how could you compare ELIOT procedure versus TARGET?
Okay, very, very important. When the first results were published in 2012, when ELIOT and TARGET results were published, I met Professor Orekia in a conference, and it was those days we were meeting each other because there was no COVID. And he said, oh, Jay, yes, you won. I said, well, this is not a fight. it is not a thing, but yes, we are going to get intrabeam, and they got intrabeam actually. So now reason why it didn't happen, I think this is my hypothesis, is that there is a lot of tissue dissection. You dissect the anterior surface, the posterior surface, you take it off. So what happens is, this is the part which is getting the radiation in the center. And that part has got blood supply coming from here and here at the edge, at the end of your, and we know for flaps what happens. This is the tissue that has immediately been devascularized. They got a lot of fat necrosis as well. So this tissue which is devascularized is the place where you're going to get the recurrence, and that's the area which is being irradiated. And devascularized tissue with low oxygen saturation, it might improve with time, but on that day when it is cut, it may not be high. And which is why I think the radiotherapy effect is lower. That could be the reason. I can't think of any other reason. And other things might be the dose and the 5 gray to 5 to 20 gray, the differential dose, rather than 20 gray given all over, maybe that has an effect biologically. But that is the only reason I can think of. There were some high-risk lobular cancers were not excluded in there, and they never gave whole breast radiotherapy. But even those who got just target, we had the same results.
Okay, we also have some experience with Dr. Beshe as well. So we use ELIOT in our patients. So we observed more seroma, for example, and we put drains more longer. We keep the drains more longer. So Dr. Karanlık from Istanbul actually is also asking a similar question regarding any complications following target procedure.
Okay.
So do you observe more seromas or other surgical complications, wound problems with wound healing?
We didn't find any delayed wound healing. We had slightly increased seroma needing aspiration, 2% versus 1%. Just
more seroma.
2% patients in target, 2.1% needed seroma that needed aspiration, compared with 0.8% in those with who didn't have target.
Do you put drains, always drains? No, just aspiration. You aspirate if there is any stroke.
And it is only 2%.
2%, okay.
It's not much compared with 1%. And radiotherapy complications were again 2% with EBRT and 1% with target, 0.5% with target.
Okay, and Dr. Kuhn make an excellent comment, and I also want to stress that one. He says that we have to take into account IMRT, hypofractionation, ultra-hypofractionation, partial external irradiation, and also data from EBCTCG, that only patients from older trial had worse on breast cancer-related mortality. Yes, that's the evidence-based. Yes. From early breast cancer trial group. Now they stress that we do not see serious cardiac toxicity in recent planning methods and treatment delivery methods.
It's a very important comment, and that is what has been said now, is that now we have better methods, therefore there is less toxicity. We have breath holding. Breath holding has never been proven in a randomized trial to reduce cardiac mortality, never. And we don't know what is the minimum dose required for the anterior coronary artery that causes the damage. We don't know that.
We don't know yet, yes.
And the study from Oxford, which is showed about smokers and lung cancer, that is not old methods, that is modern radiotherapy techniques. So the increased mortality of 23% in smokers is in modern radiotherapy. So although we may want to believe that we should take breath holding, and I've said everybody who can do it should do it, but we have not yet proven that it works. By theory, lower the dose, less is the harm, correct. But up to 2 gray, the mutagenicity goes up. About 2 gray, mutagenicity may not go up. So small dose may be enough to cause mutagenesis in terms of other cancers. And we don't exactly know how cardiac perfusion defects occur. So it's good that we're taking all the benefit, but that is being based on a leap of faith that reduced dose will be better. And I don't think it's a much trial. Go on.
There is also another question from Dr. Hasan Karanlık. So what do you think about using this technique for patients with smaller tumors who were treated with neoadjuvant chemotherapy? Like, for example, we treat some patients with a tumor size more than 1 centimeter, triple negative or HER2 positive disease. So could we also start to use this technique for those selected patients who were treated with neoadjuvant chemotherapy?
I'll answer that in 2 parts. One part is, firstly, we did not have neoadjuvant patients in the trial, so we don't really know. But I don't see logically small tumors can be excised properly with clear margins. I can't see a reason not to give intraoperative as a treatment. So logically, I think the answer is yes. My second part is I don't see any benefit. No evidence of zero benefit or negative benefit in patients who have got tumors which have operable breast cancer suitable for breast conserving surgery to be given neoadjuvant chemotherapy. So that's a separate lecture altogether. I've published in the BMJ about it. and we can talk about it in a separate talk, but neoadjuvant chemotherapy is overused, and it is just plain wrong in most patients.
Of course, these patients should be with a clinically negative axilla, right? So this should be very selected patients.
Yeah, indeed. Yeah.
And there are also some more questions regarding the risk of radiation in the operating room from Azerbaijan, from Hakikat Valieva.
Yes. So in the operation theater, because this energy is not high, we put a shield, a lead shield on the patient. As you saw in one of the photographs, we put a lead shield. After you put the applicator in, you put a lead shield this way, you put a lead shield that way, this way and this way. Okay. So hardly any radiation goes out of the patient. And the anesthetist stands behind a screen, the screen that we normally use in X-ray departments. And the walls of the theater, if they're cement walls, that's enough. But before a theater is used, people can go and check what the radiation dose is. The dose is like the dose which we would, as surgeons, we would have used it for cholangiography during theater, or orthopedic surgeons would use it for screening for their joint placement. So the dose is not high dose. It's not very high energy X-rays. So which is why operation theater, you don't have to have a steel wall or reinforced walls of operation theater for this operation. It can be done in a standard operation theaters.
I want to make a final comment, actually. You know, these are intraoperative radiotherapy is a part of accelerated partial breast irradiation, but there are other types like HDR or external beam irradiation, but they also take 1 week. And after the fast forward trial, they are not accelerated anymore. So only intraoperative radiotherapy stays as accelerated partial beam irradiation, right?
You're right. Thank you. And I would like to ask if anyone of you and in the audience are interested in starting to use this, please get in touch. There is an opportunity to take part in the TARGIT B trial and to start using it in your patients. I don't get any commission, or I don't get any part of the profit, unfortunately. Any of you start using it, otherwise I could stop practicing. But yeah, I should have patented it. But that is how it is. But please do try. Patients want it, and it's very, very satisfying to give it to patients, particularly in COVID times and so on. Yeah. So let me know if you're interested in using it.
So thank you very much, Dr. Jayant. It's a great pleasure to meet you. There are many trials, but the results are not as interesting as yours. So kudos again. And I also thank to Bahadur Güllüoğlu. Hope to meet you in Breast Istambul face to face. And thank you all again.
Thank you. It is just fortunate it is a randomized trial. It just happened to work.
We would like also to thank all the attendees for their nice questions and comments. And thank you so much, Dr. Vaidya, again, for joining us, for sharing time with us in this club meeting. Thanks so much.
Thank you very much. It's been a real pleasure.
Thank you, Jay, for your kind, we're so much would like to say our gratitude to you just accepting our invitation for tonight. That was marvelous, as always. And we're looking forward to see you next October in Istambul. And now this is the end of tonight's meeting. And we will be getting together next 29th of April. The next meeting we will host Dr. Viviane Galimberti from Milan, Italy. She will be presenting us one of her recent studies called Long-Term Standard Sentinel Node Biopsy after Neoadjuvant Chemotherapy in Breast Cancer. And she will be presenting their single institution result for 10 years follow-up. And until that time, please take care. See you that time. Again, thank you very much, Jay. Bye-bye.
Bye. Have a nice evening. Bye-bye.
Thank you. Bye-bye.